Excellent. All right, so we're going to jump on in to this discussion about orofacial myofunctional disorders, specifically the tongue. It's going to be a big driver in these things. And I just want to preface this that I love how this discussion came about. Dr. Ron gave me a call just a few weeks ago and was like, hey, we have this patient. He's got a high vaulted palate. I don't remember if you said vaulted, Dr. Ron, but he's basically, that's what he meant, was he's got this high palate. And I remember you said that there are things about the palate and ADHD. Can you tell me more? And for Dr. Ron, did I tell him more? I just jumped on in because obviously this is something I'm very passionate about because it is highly tied together, and you'll see a little bit why in regards to our patients, this population that have ADHD, depression, all of these things. So we're just going to go ahead and jump on in. Let me get you guys real quick. All right. So the overview that we're going to this is our overviews. We're going to talk about healthy development because we need to understand that before we can understand atypical development and where things go off the rails and why this has an impact on us. Can you guys see my presentation okay? Okay. So we're also going to talk about then the neurological impacts and the red flags that we should be watching out for. This is where I really want people to pay attention. I'm going to go into the weeds a bit in the science, but as far as for parents, what you can really take home is what do I need to look out for? How does this impact me at home? Then what do you do? Okay, what do you do if you think that your child or you as an adult have an orofacial myofunctional disorder? All right, then we're going to talk about the importance of a team approach. And I'm just going to say at the outset, do not leave this presentation and say, I'm going to go get a tongue tie release. Okay, I'm just going to put that out there. We're going to talk about tongue ties, but please, please, please listen. It needs to be a team approach. And there's certain aspects that you want to take care of before you go and do that. I just always make that disclaimer. All right. Swallowing development in utero. It is incredible when we have a newborn baby that we see in the hospital, and especially if we see, or at a home birth, you see this baby and they latch and they're able to suck, swallow, breathe without any difficulty. It's a beautiful, wonderful thing. However, that suck, swallow, breathe pattern has already been at work. It has been shaping the cranium and development for months. So this is something, you know, as soon as the baby is born, people will be like, oh, they're born with a tongue tie. Let's go ahead and the term they'll say is clip it because, oh, maybe that was impeding things. But we need to go back that this baby has been shaping their suck, swallow, breathe pattern and their their GI tract for weeks and weeks while they're in utero, because between that 8 and 10 week time, the brain is really shaping, as is the mouth. That is when we have a lot of these fusions that come together, these midline structures, and we have the initiation of the pharyngeal swallow. This is a very big deal. At this stage, you start to see that this baby is getting that suck. We have between 18 and 24 weeks in utero, that true suckling pattern observed. The baby is really getting efficient at how they're moving their tongue and how they're getting that amniotic fluid that they're swallowing, and they're practicing that swallow at that time. At 28 weeks, that's where we start to see the tongue in the baby, in their mouth. It's cupping, which is a very important movement that we want to see because that is for bolus formation, or what we would say is you can actually swallow cohesively and control things at 28 weeks. Okay, so this kiddo, even if they were born prematurely, they're still not out. Usually they're still inside the mother for a little bit longer. 34 to 37 weeks, that's when we really can sustain nutrition orally. Okay, this is what I mean. These patterns have been hard at work. Baby has been getting more and more efficient. And the reason that plays a part is how it impacts the cranium and the whole system. So in utero, the rhythm of movement that facilitates this growth and cellular organization is cephalocaudal. So what that means is that the pulsing, that movement is from the head to the tail. So as this swallow movement is progressing, we are actually shaping the face. We are shaping all of the structures of the cranium and the spine through this movement. The swallowing pattern in utero should consist of a tongue elevating to the maxilla, which I don't know, can you guys see me as well on your screen? Because I have a little skull here that I like to show. So the tongue should be going up to this red bone, okay, to the maxilla. It should elevate there, provide input to the cranium through that swallow. We should be getting the tongue going up, hitting the maxilla and giving this midline input that then facilitates this beautiful rhythm of growth through the cranium. All of these different sutures that are coming together in the skull, in the face, they're getting this pulsing rhythmic growth out. The tongue moves fluid from the front of the mouth to the back. The pressure and the release of the swallow achieved in the mouth pulses down the core with the stabilization of the pelvic floor. I'm going to highlight that because it's very important, because sometimes in what we're doing with myofunctional therapy, we may need to address pelvic floor dysfunction before we can address things in the mouth. So what we need to see is this pattern's important. We should be shaping a very solid, beautiful swallow pattern with really nice valsalva, really good peristalsis all the way down, so that we have really nice digestive patterns and clearance patterns. If we run into issues anywhere along that line, we're going to have issues back up at the top. So the GI tract is shaped. Oh, did you have a question?
Yeah, Karindy, can I see some people writing. Can we get a copy of your PowerPoint?
Yeah, of course.
Okay, we'll upload it also. I know they're trying so hard to keep up, but it's just impossible. So
man, this is my slow version. I really was like, take out some of the things. We'll see. Okay. All right. So I'll just say that the GI tract is shaped and strengthened through the pressure force of the swallow. All right. As this baby is shaping, forming, we're developing and strengthening all of these junctures, all of these different tight places that should stay tight. They shouldn't be open. Okay. Atypical, this is usually where I come in, okay? This is the population I see, and I will say in general, this is the population that we need to know about, okay? When the tongue is tethered tightly to the mandible, which is the jaw, and unable to fully elevate to the palate, which again is this red bone, the maxilla, we want the tongue to be up there. Everybody take a second, and I want you to know where your tongue is. I'm not gonna watch, I promise, but I want you to just feel, is my tongue low on my bottom teeth? Is it kind of back by my throat? Is it up on my palate? Is just the tip up? Is the whole tongue up? Pay attention to these things because it matters. The tongue tries to elevate to move the fluid back, but the tongue is unable to make that full motion, okay? Rather than the tongue resting in the maxilla, building this beautiful shape. So I'll just give a little demonstration again with my hands. I always think they're a skull and a tongue, but we should have this beautiful dental arch that should be a perfect puzzle piece to fit together with our tongue. Our tongue is what shapes our face. It's the braces for our face, all of this formation. If the tongue, however, is not resting in the palate, if it's resting low, guess what? Baby is still swallowing, still sucking. But now these cheeks, they're very effective. They send a huge force in. We're sucking, but the tongue is no longer the scaffold that's holding the bones together and helping them have beautiful shape and growth. Instead, it's low. So you know what? That palatine suture, that midline structure right here, instead of it having this wide, nice palate, we're going to go up. We're going to take away space from the nose. And this is where we start to get that high vaulted palate. And as it gets higher and higher, it's harder and harder to get the tongue to rest up there. So early intervention is wonderful. All right, I'll say that, sorry, I kind of jumped ahead of myself, but the palate begins to grow high and narrow rather than wide and sloped. I wanted to show this picture of tongue ties. Okay, this is a beautiful resource. It is by the Breathe Institute. Soroush Zaghi is an ENT who's put it together, and I want you guys to all look it up. It's just ferris.org. It's a free tool that you can go ahead and print out. take it to your dentist and ask them, have you seen this? Take it to your ENT and ask them, have you seen this? It's a great resource to have. This one doesn't show babies and children, but I wanted you to see in general what tongue ties look like. Okay, just look at that picture of the grade 4, that TRMR tip. Look at how tight that is. Okay, so I want to bring this up because you can have a tongue tie and be very functional. I've seen adults that have an anterior tongue tie. That means that the tongue is tethered right at the tip, and they speak fine. They've never, well, they don't remember ever having feeding issues. They're like, it's always been fine, but at what expense? Their body is straining, their platysma is tight, their neck, everything is working really hard. The floor of the mouth is lifting to try and give them that elevation. So I bring that up because how much energy are we spending to just lift the tongue to be functional if we have this structural restriction? So lingual structure restrictions, known as tethered oral tissues, always affect lingual movements. Even if they don't necessarily need to be released, they're going to affect your body, and we need to know that. So the impacts are going to be on infants. That the nursing latch is shallow. They're having difficulty. They might have spillage around the sides. They're going to be fussy because they're not getting that full, beautiful contact of the tongue going up to the palate. They're getting a lot of air in there. These babies, it's often, they're gassy, they're uncomfortable because as they're working so hard to swallow, they're getting a lot of that down in there. And they're having to utilize a lot of different movements. Their shoulders coming up, they're really working hard. So you might see more muscle strains, more tension. It's not uncommon to see torticollis in these little ones. And they go together. We can have this tension pattern is starting, and look at their feet. If you'll start to see, they're curling in on their feet. They're curling in and they're tight on that side of the body. It's all connected. Older babies, this is where we're going to see that highly responsive gag reflex, because rather than their tongue resting up in their palate and desensitizing all of the oral structures, nothing's been in there. Their tongue has been low, and while fluid has gone in there and they've managed it, maybe they've choked a little bit on it, but they got through it. By the time we get to solids, we get to purees, baby goes, whoa, I do not want that in there. What is that? That's a danger to my airway. And we might have very quickly an aversion. So they're resistant to trying these things, and they might be considered a difficult little one, where they're just going, no, this is dangerous to my airway. So they're mouth breathing rather than nasal breathing. We'll get into that a little bit later about why we want to be nasal breathing all the time, okay? When it comes to toddlers, this is where it gets even more tricky. Now we're having, they're becoming these fully individual, they want to be by themselves, basically. They want to manage their own food, all these things, but they know what they don't like, okay? They know what they don't want in their mouth, and they know what things scare them. Right, so these are going to be the ones that are trying to soothe themselves. They haven't been able to get their tongue up to the incisive papilla, which is very important to spot because we have a lot of serotonin receptors that are there. This is why a child will suck their thumb, they'll suck a blanket, they're going to have the pacifier. It's very beneficial for that cerebral spinal fluid flow and for the cranial rhythms for them to have input up there. But it shouldn't be their thumb. It shouldn't be the pacifier. It should be their tongue that is providing that stabilization and that input. But kids are smart. They will go, you know what, my cranium's locked up. That cerebral spinal fluid flow, it's limited. I need movement. My sacrum's locked. My occiput is locked. I'm going to move it. And so they'll put their thumb up there. That's why when kiddos come, I do not go, let's put nasty stuff on the thumb or whatever. First, let's give them some skills so they can start moving their tongue up into that space so they can naturally treat these issues that they're trying to take care of themselves. So their sleep is generally not very good, okay? Even if they lay down and they are sleeping, it's light, okay? You'll see behavioral issues. These are the kiddos that they have tantrums all the time because guess what? They're exhausted. They are tired. They are not able to show up and be curious because they're just trying to survive. They're in fight or flight. You might see these rashes, they're coming out. Their body is inflamed, and we'll get into why in just a little bit. So let me stop jumping ahead of myself. I wanted to show this picture for you all to see. Print out this amazing article by Baxter and his team. He is a dentist in Alabama, and he's put together some amazing information. But take a look at this. Okay, so in school-age children who have orofacial myofunctional disorders, in this article, he's specifically talking about tongue ties. I do want to clarify, you can have an orofacial myofunctional disorder and not have a tongue tie. It is not dependent, okay? But what an orofacial myofunctional disorder is, maybe your tongue could move, but for some reason, you had these massive tonsils and adenoids, and so you had to mouth breathe for an extended period of time, even though your tongue could have fit up there for whatever reason, you had asthma and these other things, you couldn't do that. So you breathed with an open mouth for a while. Guess what? You started shaping your cranium and your palate real quick. And then by the time you could get your tongue back up there, your palate had shifted and moved and doesn't fit anymore. Okay, so these are some reasons, but I want you to see the whole scope, the whole picture of it. So you see here, we have snoring in these school-age kiddos, okay? We have picky eating, restless sleep, mouth breathing at night. Bruxing is going to be when they're clenching, they're making loud sounds, and that's, they're trying to, in general, they're trying to dilate their airway, because when we brux, when we clench, we send a lot of proprioceptive input to the trigeminal nerve. We wake things up and we tighten those pharyngeal muscles, gives us a little bit more dilation of the airway space, okay? This is something why, if you see they're grinding it down, might be for a reason. So sometimes, guys, if we put a bite guard in there, you might be taking away that advantage that you got of opening up that palatine suture every time you clenched and ground your teeth. You're trying to get a little bit more airway space, but I digress. So slow eating, these are going to be the ones that are having difficulty. They can't get their tongue to move back there. So maybe they just give up. They're tired. Okay, they have speech delays, sinus issues, and then here's the biggie, hyperactivity and ADHD. I will say, I see the whole age range. I see babies to adults. Okay, so this is what breaks my heart, is when we have adults that come in and they tell me, oh yeah, I had this as a child. My mom told me that I was so difficult to breastfeed, that she had to, I had to have a bottle. I had to do these things. I was a difficult child, all of these things. I was started on meds real early, and now they're coming because they're having terrible migraines and depression, okay? Anxiety, depression, focus and concentration issues. We see huge numbers, okay? There's more and more research coming out, so we're going to have even more information and data to collect to provide people that really, we need to be looking, when there's a mental health disorder, can we take a look and see if they can breathe? We really need to do this. It's so important, okay? So fascia strain, that's even its own. Let's say you can breathe, but it's a lot of work. You're able to make it work. This is where I love the whoop strap. I don't know if you guys are familiar with it. It can take a look at strain. So sometimes, people will be like, I'm breathing fine. I have 100% oxygen, but how much effort do they have to expend to get to that? They're exhausted just walking around trying to maintain posture because they're fascial strain, which fascia is connective tissue throughout the body, which is what we're talking about when we have a tethered oral tissue or tongue tie, is fascia that is too thick and too short, so the tongue doesn't have full range of motion. Guess what? You also can have tethering throughout the body. This is why it's so important to get body work, because if you have tethering that is impacting the diaphragm, and you don't have full expansion and contraction of the diaphragm, you might need to stabilize your breathing through your tongue. It acts as the second diaphragm for you to lift and to breathe. So don't get a tongue tie release until you get a full body workup, because you might be compensating and actually have more range of motion of your tongue than you realized, but you couldn't because your pelvic floor was all tilted. Okay. Before giving a cognitive or behavioral diagnosis, I would love it if everybody just asked their doctor, just ask, can we please consider a sleep study? And when I say a sleep study, I say a study that actually looks at them sleep, because I have been blown away by, sometimes I'll see, the parents, they bring in a sleep study and the child slept for 90 minutes because the rest of the time while they were there, from 8 o'clock to 4:30 a.m., they were running around and they were screaming and they were hitting the walls and they couldn't get them. And this is while they're on sleep medication, and they were trying to get them to sleep. Finally, they pass out 4:30 a.m. and then they fall asleep until 6 o'clock. they didn't have any apneic events. So guess what? They passed their sleep study. In my world, that doesn't count, okay? That is not a sleep study that gives me information other than that this poor child is doing anything to not get in that bed and lay down in a place where their body goes into fight or flight because they start choking because they can't sleep or they can't breathe while they're sleeping. So I would just say it's very, very important. And then the myofunctional exam, because even if you got a tongue in your mouth, but if you can't move it around, you can't get it out of your airway, you're going to be compensating in other ways. So I bring these things together because look at the areas that we impact our body or that are impacted when we do not have optimal breathing and when we're not in a rest state. So if I'm able to breathe, but it takes a lot of strain, a lot of work, and a lot of concentration, I'm not able to show up fully. My mitochondria are very dependent on oxygen, okay? They need that for ATP, okay? We're human beings, we need ATP. Mitochondria need that oxygen to turn around this whole process to give us energy. If we don't have that oxygen, they don't work so great, okay? We're gonna be sluggish. Sleep quality and quantity, it really depends on the quality and the quantity for us to have lymphatic cleaning of the brain. Okay, there's proteins, they're not cleared out when we're awake. That lymphatic system is really churning out and clearing out things that put us at risk for Alzheimer's, okay? We wanna sleep, we wanna clean out the sludge. We're not sleeping, we're not breathing, we're at higher risk for things. And I will stay in my scope, but I'll just say, eek, okay? Think about that one for a minute. Central nervous system, fight or flight, okay? Everyone nowadays is pretty much a fight or flight. Okay, we have lights on, we have electromagnetic, all kinds of things. Our diet is inflammatory. We are under attack, at least perceived attack, all of the time. Add into that the stress that your body goes, and I can't really breathe. Okay, I'm not going to behave very nicely in traffic if I have to really toggle my decision-making to breathing rather than, not having road rage. Okay, these are things that, how much are we impacting our society by not breathing so great? Nitric oxide and oxygen exchange. Okay, this is modulated through nasal breathing, which in Texas, okay, can we just say it is hard to breathe through your nose in Texas? Okay, it just is. I mean, looking outside and it's like yellow. So we've got pollen, we've got all kinds of things, and then we have pollution. We have all of this. However, if we're not breathing through our nose, which is getting clogged, what are we breathing through? We're breathing through our mouth, okay? This is where we see these tonsils that become huge. If you look back and your tonsils are kissing, that's not a good thing. However, I will say just going in and taking them out, that isn't necessary at times, but it's the canary in the coal mine. It's telling us that our body is under attack. It has more than it can keep up with. Okay, our lymphatic system, if you feel along here, it's all just bumps. Your lymphatic system's clogged up because we're not moving. I mean, I'm sitting, we're all sitting. We're not moving and pumping our lymphatic system the way that we should. So we're getting more toxins, we're getting more debris. If we're not breathing through our nose, which has that cilia that can actually clear the air and get it to our lungs in a good, healthy way, then we're breathing through our mouths. And the only net we maybe have, those tonsils back there are like, okay, that's not a great solution. So we need to be breathing through our noses, getting that nitric oxide. And that is really, we want that for vascular input. We want nitric oxide for inflammation support to bring it down. Circadian rhythms, guys. Okay, we can talk about light, we can talk about sleep hygiene, we can talk about all these things. But again, if you wake up 3 o'clock in the morning because your body finally got into this deep state of sleep, even though you're exhausted, and all your tissues start to collapse because you no longer have those hormones that are keeping things tight, and you have this huge choking event, you wake up and you're in fight or flight, and your body goes, oh gosh, that messes with your circadian rhythm. Our circadian rhythm messes with our hormones. Messing with our hormones makes a big impact on our vitamin D. Are we able to actually utilize that? Our pH starts to shift, and that goes back into nitric oxide as well. if we don't have sufficient pH acidity in our gut, okay, H. pylori, come on. I mean, we have these things, and then, oh, now we can't utilize nutrients that we're actually eating in our diet that may be minerally deficient, but that's okay. We usually could get by, but even if you're taking a vitamin, if you don't have that pH to support you actually absorbing it, it's just going through, guys. It's just going through. So circadian rhythm, we want to have that so we can sleep, so we can actually feel that, oh, it's daytime or nighttime, and we can respond as we need to. So the lymphatic drainage in the pineal gland. Okay, I want to talk about this because we also, so I talk about walking and moving. That should be pumping our lymphatic system and clearing it out. So should our tongue. Okay, our tongue is it's a beautiful lymphatic pump. And when the tongue elevates in the back, so it shouldn't just be the tip of the tongue should elevate in the very back and get up into the posterior portion of the palate. We have, I'm not going to take the skull apart because it takes too long to get it back together, but I will say back in here, we have this beautiful juncture, okay, that right here, the maxilla, all these things come together, the occiput, the sphenoid. Here, I will take it apart because it doesn't make sense if I don't. All right, so these, they come together and we have the pineal gland. It rests right up here. It should be having this beautiful, it doesn't move this much. This would be a big time brain injury, but it should have a little bit of a pulsing back and forth, and that pineal gland is getting input, okay, as we are swallowing and it's moving back. We're getting that really nice rhythmic input. I see on CBCTs, which are cone beam CT scans, patients will get them to take a look and see what the sinuses look like, see what's going on with their mouth. And then sometimes they'll remark that the pineal gland shows calcifications. Guess what? If you don't have that nitric oxide, you don't have oxygenation, and you're not getting that manual pumping of the tongue that it moves that joint in the cranium, you're not getting movement throughout the pineal gland. Things get sedentary. They don't drain. We get calcifications. However, it's beautiful to see that when a patient does myofunctional therapy, does the work, gets body work, starts working on things, sometimes they might also do different breath work exercises, all of a sudden we can see shifts. Those calcifications start to go away. There are other things we can do that improve it even more, but that is very important, again, for circadian rhythm. So I did want to say, in regards to, if you took nothing else away, okay, nasal breathing on its own improves oxygen in our bloodstream by 18%. Okay, so you can forget all the other stuff. I don't think you should, but you could, and just go, I still should focus on these things so I can breathe through my nose and increase my blood oxygen levels. It's that important. So this, I'm glad I'm going to share. This is straight from the Oxygen Advantage website. It's a wonderful resource. Okay, so you guys you can go there right now and look it up. It talks about all of these benefits. Have this as a handout for your patients, for your clients, for people you work with, and say, hey, these are benefits, okay? And then, they can try it at home. There are different things. I would say James Nestor's book, Breath, if you haven't read it, is phenomenal, okay? It's also, it's like an easy, fun read, okay? So these are great resources to have. I want to jump into the red flags, right? So you may have picked up on some of them just based on what I'm talking about, okay? We can assume that if a child is waking up a lot at night, if they're bruxing and clenching, that's a red flag, okay? So frustration with communication, trouble with speech sounds. I will say, in regards to tongue ties specifically, STRDNL, these are big ones. All these kinds of words that really, it takes that articulation, movement. I have issues with that. And you see all the things we have here. We have headaches, jaw joint issues. I will also add something that Baxter didn't mention on this questionnaire is going to be fluency. I see disfluencies often because if you have a tongue tie that's restricting range of motion of your breath pattern, it's harder to maintain that forward flowing motion that you need for speech. Speech moves fast. If we have reduced breath capacity, it's hard to speak in sentences. It's also hard to, again, that forward flowing motion of the articulators, the tongue doesn't move as easily when it's really tethered down. So it does these other things and it might get stuck, okay? It's tricky. I will say hyperactivity and inattention. This is such a huge one, okay? And again, how many times are kids labeled problem children or disobedient or obstinate? And it's just, again, they're not breathing efficiently, or they're under strain, or they're in this fight or flight because of these issues. So what do you do? Okay, what do you do if you suspect that there's an issue going on with you or someone you know? First, you can go get a myofunctional exam, okay? You can find orofacial myofunctional therapists anywhere. We have lots that are RDHs. You can find speech therapists. You can find individuals that are trained that are PTs and OTs. So you can look at the IAOM, the AOMT. There are, the Gillespie approach is a Facebook group that's on Facebook. You can look there and they have lots of resources, okay? I would just say there are people out there, and this is something, the Airway Circle is a great resource as well. And you can look up in their directory who's around. So then I would say, this is something that I'm a little obsessed with, is I want you to see someone to get the body moving, okay? A pediatric chiropractor, an osteopath, I love it when they're specifically trained in craniopathy, which is going to be a Martin Rosen technique. So he's up in Boston, but he trains lots of chiropractors throughout the US and the world in craniopathy, which is the specific adjustment of the cranium through the mouth, okay? This is a fantastic resource, and I see huge changes. Like the sphenoid, I can do, which the sphenoid bone, it's the coolest bone. Okay, it looks like a flying bird. All right, that bone back there though, it's so important because the whole cranium, it shifts and moves around from it, okay? But they can go in and they can get things moving. And sometimes let's say a baby is having difficulty with that suck swallow pattern. Temporal bone is locked up, but it's because of the sphenoid. Okay, they get in there, they start moving these things. All of a sudden, because we don't have that cranial nerve impingement, suck swallow, it's back on board. Okay, these are huge benefits. So get an evaluation with a body worker. Some great resources are going to be the Gillespie approach. This is craniosacral fascia therapy, which is a gentle fascia release. And it really is just feeling the pulling and the pushing of the fascial system to let it unwind itself. The Peak Potential Institute, as I mentioned, and then craniosacral therapists, these are all great resources. Get an evaluation with a provider, like an airway focused dentist or an airway focused ENT, which they should all be airway focused, but not all recognize tongue ties as being a thing. And they might be like, no, the tonsils are huge. It's okay. So I would rather someone who doesn't just want to wait and see. I would rather have a plan of something. Let's do something and get something to shift. So for babies, I would love for them to see a lactation consultant, okay? And then older ones, babies, toddlers, they can see SLPs, OTs, PTs for therapy to try and get, again, when they're little, a lot of it looks very similar, okay? We're getting the body to move, we're getting things in the mouth, shifting things around. And then as they get older, they can see specifically registered dental hygienists that are myofunctional disorders. So 4 years and up, that's their specialty. They're really great at it. So I want you to know all these things, but like I said, do not go get a tongue tie release today, guys, okay? I did this. This is why I share this information. When I was learning about tongue ties, I was like, sweet. I took my son in to go get an evaluation, and then the ENT was like, we can do yours. I was like, I've done nothing to prepare. And he was like, it's fine. Okay, it was not fine, guys. Thankfully, I can speak, but learn from my experience. Don't be overzealous. Do the work. It's worth it. So I will say the reason a team approach matters, and then I'm going to wrap it up pretty quick, is because we have those midline structures. The tongue is so important proprioceptively. When I see a child that has had 3 tongue tie releases and they bring them to me because they're like, we're going to get a fourth. Stop. Hard stop. There's a reason the body is rejecting this, okay? The body, typically they need the tongue to be the anchor for them to breathe, okay? But there could be other things. But I would just say, if you've had one or two, stop, reassess, give the body a chance to shift and reorient and see what might be happening. It might just be stress and strain in the ecology of the family. Maybe we've got a lot going on, some socioeconomic things that might be shifting the strain and the stress of the child, of the parents, okay? Take a break, take a breath, it's okay. We don't need to do anything right now. We just need to let the body unwind and heal and find its new midline, proprioceptively reorient to where it is so it can move from that space. All right. I will say, if you have more questions, you can go ahead and jump on. I'm on Instagram, getting more and more consistent on there at Myohacker SLP. And then I have a community where I have information for what in general, just a free community. And then I have a cohort. It's actually starting next week for parents. This is not therapy, but it's training, because I have found so many times that parents come in to see me, and guys, you've now experienced it yourselves. It's a bit of a deluge of information that comes out of my mouth. So I've wanted to give parents a pre-training of what to expect, what myofunctional therapy looks like, why we recommend body work, why we don't recommend just go get a release and then you're off on your own, all of this information. So I have that in a course that's starting next week. And then currently we have a lovely group of providers, and we've been enjoying this cohort, but we have another one starting at the end of June. So you're welcome to join that one, but that one is for providers only, because it goes really deep into some research articles and different things. So feel free to take a look at those. And then I did want to share, so I have some references there. And then this is a wonderful resource, because I know you guys are going to go out and you're likely going to talk to people who say that this is all just fake. It's not. So what I want you to do is take a look at this. It's a great resource and it's updated monthly. It is by Robin Merkel Walsh, Lori Overland, Christy Gatto, and Ashley Larson. And it is updated all the time, and it has all the new research articles that are coming out. So when you go to the ENT or the dentist or the pediatric, for anyone, whoever you see, and they're like, that doesn't exist, you can just be like, here are 37 articles. So, all right, time to jump into questions.
Yes, and we already have some comments and questions in the chat box.
Oh, cool.
So I can go ahead and start going through those. Amy commented, great job. You are amazing and gift to us all. And also made another comment, calcifications, there also are implicated in biotin illness. Courtney also said, yes, I can't wait for there to be more research between ties and fluency. And one of the questions.
I was saying biotoxin illness through Dr. Alyssa Jones and others. If I see calcifications in the sphenoid, ethmoid, or any of those areas, I'm always suspicious of mold toxicity or something like that.
Great information.
Yeah, that is really good information. So
can we talk about that for a second, actually? Yeah. Amy, do you want to can we jump in and talk about mold? I think we need to go there.
Yeah. You think? Go ahead. Me?
Yes.
You.
Okay, let's see. In working with ALF patients, one of the things, it's a really gentle light wire appliance, but with babies, sometimes we use like Essex type material, which is like a gentle plastic. But basically what we're really doing in the first months of ALF is almost osteopathic and unwinding and things like that. And how I came upon mold at all or anything about it, aside in my own personal journey, was that I would have some patients who really were not progressing the way that we would expect them to progress in ALF. And what that often looked like wasn't so much the teeth not shifting and moving in the jaws, but their sleep not getting better. And so just had a few patients where one was about to get diagnosed with what's it called? Bipolar at 7, and was suicidal and homicidal. And homicidal towards siblings. And he had had a lot of other diagnoses in the first few years of life, including autism, which was not an accurate diagnosis and so forth. But anyway, long story short, we sat with it. I think it was Karindy and some others maybe in this group who was like, has there been mold? And so I reached out. So that kind of opened my eyes to it. And since then, I see scans on kids all the time. I've seen a pretty consistent, it's pretty consistent when I see calcifications or a lot of congestion up high in the sinuses with it being biotoxin illness. And we're almost 100% every time we send kids to be tested for mold. And I know sometimes it could be Lyme's as well, but I don't know as much about that. But when we send them, that is a big problem for them, and that impacts their sleep, as probably everybody here knows, as well as behaviors. But I also have a case of a patient that didn't know they had mold and a lot of other genetic things going on. And they had so much congestion everywhere. Like it was like, how is this kid even breathing all the way up the skull? And 8 months later, we took a new 3D because the pediatrician wanted to send again for another adenoidectomy. And I was like, I don't think adenoids are a problem. We scanned, adenoids weren't a problem, or tonsils, but in 8 months' time, it was really dramatic how much just having the Alphin cleared a lot of that. So myofunctional therapy is helping to clear it. You still have to have binders if you're in 24% of the population has an epigenetic change that doesn't allow them to clear the biotoxin. And so it's kind of collects in different places. For children, adenoids and tonsils is a place where it really likes to colonate, and then it releases myotoxins, which are poisons, and it goes up, passes the blood-brain barrier. It can also be passed via the placenta. And so, so a lot of people weren't clearing, but with myofunctional therapy, that helps. The ALF is a biomimetic tongue, so it also helps clearing. But if they're in that percentage of the population, they still need to take binders. But is that what you wanted me to say?
Yes. And I just think it's so important when we have these patients. Okay, if we're talking heavy metals, we're talking any of these things. You know, if we have, sorry, I don't know if you guys can see me now easier, but heavy metals, mold, Lyme, all of these things, if the inflammation response in general is elevated and the body isn't able to tolerate these things, it doesn't even, well, it matters, but to any degree, if you have an onslaught, if you have an attack of these, toxins, it's just not going to be handled as well. Whether you have an epigenetic disposition that is going to help you get through it easier or not, if you might be more vulnerable to some of these things, if you're not breathing as well, if you're not able to utilize that lymphatic drainage as well, you're just going to be more susceptible to illness. And, we even talked about it, well, I won't say who, I guess, but in regards to, tongue ties and seizures, because I see a lot of patients who have both. And really looking at it, it's not necessarily that the tongue tie is causing the seizure. I would not make that claim. However, there is a bit of this rain barrel effect that we have stress, and it's coming on the body. And at some part in that neurodevelopment, we had an increase in that stress to such a degree we have an overflow. We no longer can tolerate it and handle it. And how that reveals itself, sometimes it's going to be in this behavioral disorder. Sometimes it's going to be an overexcited toxicity in the brain, because, if we have this need to not have too much glutamate in the brain, but we do because of all these things that are going on. Okay, we don't have that GABA reception. We have this is your stuff, Dr. Ron. I won't jump into that, but I will just say that we see these things more and more. Okay, do we have questions, other things before I go off?
Yes, is the myofunctional exam covered by insurance?
It can be, and it just depends on where you go. It is, so yes, I will just say in general, finding a place that covers it, the wait lists are very long. So you can, because really it is a feeding evaluation. It should be covered under well, maybe I shouldn't be saying these things. I will just say it could be covered by insurance, but you need to check. You need to check with your insurance.
Okay, yeah. If anyone else has any questions, feel free to pop on. I see Julia raising your hand.
Just phenomenal presentation. I'm one of the ones jotting down because I just have to. That's how I was so involved in everything you were saying. It's a quick personal question. So I have a 7-month-old grandson, and he was born with a tongue tie, and we've come to find out that it's heart-shaped, which I understand is grade 4. During the first few months of his life, my son and daughter-in-law asked and asked and asked repeatedly the pediatrician what to do, and she kept saying, he's fine, he's fine, he's fine. My daughter happens to be a speech pathologist, and with her pushing, they just went a week ago to an ENT and said, this needs to be fixed. I think that they're not able to do it for another month. They said, if you would have come at 3 months or younger, we could have just done it immediately. But now, because he's 7 going on 8 months, we're going to have a special procedure where I think they have to give him sleeping gas. I just wanted you to comment on that. Really, my question is, what can be done in the community to enlighten pediatricians more, so they could have at least just said, if you're interested, here is information for you to go get it checked out. But she kept insisting he was fine.
I will say, sadly, I see this all the time. I experienced it as I am a speech language pathologist that came from the hospital-based system. So it was ingrained in my brain that tongue ties were not a thing. It was a very big deal at one of the hospitals that I was a part of, that it's not a thing. It doesn't matter. Just walk away if someone talks about it. So I will say there's a lot of pressure that pediatricians themselves are under to go, oof, that isn't a thing. And there is a lot of research out there that is sadly terrible, that talks about how tongue ties, they don't even matter. Maybe they matter in infants, but then it doesn't matter beyond that. I will say, in general, taking that Ferris form to your pediatrician can be something to do, but I haven't personally had a lot of luck with getting pediatricians to necessarily be on board with it until they have a personal experience. It's usually what it takes. That's what it took for me. I was like, tongue ties, they're not possible. They're not a thing until I did everything the ENT was saying, and my child was still having ear infections. And I was like, oh, maybe this is connected. And I looked, and the research was there, and saw that when you don't have that elevation of the posterior aspect of the tongue, you're not opening the eustachian tubes, you're not getting that drainage. And guess what? You get ear infections. They go together. So took me to have a personal journey. I will say, in general, that's what it is. So right now I just go get a second opinion. Go find someone else who you don't necessarily have to educate. That's what I would tell parents. As the demand increases, the providers will get the education. When they see that they're losing people because they're going to find a provider who is well informed on these topics, that will shift. I would love, Amy, can you jump in and talk about that, the whole situation there?
I just private messaged you, Julie. You should not need sedation at 7 to 8 months old. And so, yeah, just maybe a different provider, but definitely a team approach is still relevant at that age. So having a savvy SLP do like a full assessment of how are we doing right now, and starting to work. Think of the tongue tie release as lifting the gate at the horse race. You got to train the horse a little bit to have a better outcome. And then body work to make sure from birth or in utero, whatever, there's nothing restrictive that will create tight healing afterwards. Things like that. And then making sure there's not signs of inflammation all over the baby, like cradle tap or baby acne or all these other things. If there is, then you need to investigate why there's inflammation, because that can attack the wound site. But other than that, yeah, just you're doing that on the pre and post, just find a provider who routinely treats 7 to 8 month olds without sedation, because that's absolutely not necessary. Yeah.
Well, everybody, I just want to, we're about ready to run out of time here, and I've got to go to appointment myself. I know Alexander does. There's so many questions, so many things. And I was thinking about Pam here with all the ADHD symptoms that we can have from something so mechanical, which is really sad. But like I want to tell everybody, when you're talking to Karindy, it's like drinking from a fire hydrant. you know, copy it, record it, watch this thing over and over again, because there's so much information. It's so valuable out there. And sadly to think, maybe it's going to take some lawsuits for malpractice when pediatricians don't do what they should be doing when the research is so strong and out there. Maybe it's to the hospitals that refuse to accept that this could be involved with their child's future life. This is just all real sad, but that's why I'm glad I'm part of this team we're working with to take on these difficult cases, and we want to write them up and get them out there, Amy. That's what we need to get them in front of as a pediatricians. That would be the journals. So, and I'll be glad to help you do that. So, we got a couple more minutes here, maybe a minute, but I do have to get to my appointment myself.
Yes, and this recording will be available on YouTube. All those who registered should receive the link in like 1 to 2, 3 days, depending on how quick we can get it up.
Awesome. Well, thank you, everyone.
Thank you. It was absolutely amazing. There were so many comments in the comment section just talking about how wonderful the presentation was. So phenomenal. Blown away. Thank you so
Well, go
much.
breathe, everyone. Go breathe and have an amazing day.
Thank you.
Yes, go breathe. Bye.
Thank you. Bye-bye.